And we're going to talk today about the failure of the sleeve, the band, and the Roux-en-Y, the power of the mini-gastric bypass, and successful treatment of obesity and diabetes, particularly in India. Let me start off the discussion by referencing a Medscape medical news article that appeared in the past several days, entitled Bypass Surgery for Diabetes with Non-Morbid Obesity. Maybe. This is by the reporter Marlene Busko and is dated June 4, 2013. Quote, in a new report, RNY bypass in mildly to moderately obese patients with uncontrolled diabetes had a better short-term control of their glucose and weight loss than their peers who received medications and lifestyle advice. And as you can see in the slide, this is published in JAMA 2013. The title is Roux-en-Y Gastric Bypass versus Intensive Medical Therapy, Medical Management for the Control of Type 2 Diabetes, Hypertension, and Hyperlipidemia. The Diabetes Surgery Study, Randomized Clinical Trial. And the authors, but the primary author is Dr. Erkramadden, and I found this presentation very interesting. If you read the abstract, you'll not find anywhere mentioned that there were 22 serious complications in the 60 Roux-en-Y gastric bypass patients. In other words, the abstract says, as we heard in the previous slide, that the Roux-en-Y patients, of the 120 patients, 60 randomized to Roux-en-Y gastric bypass, had better control of blood sugar. But nowhere in the abstract does it mention that over a third of patients in the Roux-en-Y group had serious complications. And the two of the most serious complications were leaks, which would give them an estimated leak rate of 3.6%. And one patient suffered anoxic brain injury and had to have a leg amputated. And that Roux-en-Y patients were more likely to have other complications, such as nutritional deficiencies. In an Associated Press article, Obesity Surgery Diabetes Study Shows Pros and Cons by LINDSEY TANNER, also June 4, 2013, quote, about a third of the 60 Roux-en-Ys developed serious problems within 1 year of the operation. Again, not mentioned in the abstract of the article. And a quote by the authors that this rate is similar to what's been seen in previous studies of Roux-en-Y bypass of patients with serious complications. And for the very most serious complications, major infection, small bowel obstruction, and bleeding, the rate was 6%. Again, from the Associated Press, the most dangerous complication occurred in one patient when the stomach contents leaked from the surgery site, that is, an anastomotic leak. It led to overwhelming infection, leg amputation, and brain injury. And again, you have to take the quotes from a newspaper article with a grain of salt. But according to this article, the lead author, an obesity surgeon at the University of Minnesota, called the case a fluke. Again from the Associated Press, Roux-en-Y patients lost nearly 60 pounds. 75%, or two-thirds, lowered their sugar levels to normal or near normal. And the JAMA editorial on this, devastating complications are rare, but, quote, the frequency and severity of complications is, quote, problematic. Problematic. Again from Medscape, just to repeat, 36% serious complications, 3+% incidence of leaks, anoxic brain injury, amputation. I would say this is not a fluke, and that instead of 75%, I would say only 75% normal or improved blood sugar. So we're going to talk about expert judgment and the latest data on weight loss surgery procedures, particularly going to talk about the band, the sleeve, the Roux-en-Y, and the mini-gastric bypass. But I think this previous study demonstrates that, published on the front page of one of the leading journals in the world medical literature, with barely a mention of a 36% serious complication rate, a 3% leak rate, brain injury within 12 months compared to control, brain injury, amputation, leaks. I don't think this is a good measure of the best we have in bariatric surgery. Let me point out there are numerous studies referring to the studies of Edward Livingston showing that in the VA studies, the Roux-en-Y and the vertical banded gastroplasty failed to cut costs or lengthen life. That bariatric surgery has a history of major complications and failure. And I feel that we need a better bariatric surgery. We need simpler, safer, more powerful, more durable, revisable, and reversible operation. I think we need the mini-gastric bypass, and that's what this talk will be about. This talk was prepared for a lecture in India and basically has 4 primary objectives. 1, to talk about obesity and diabetes as growing problems in India. 2, that surgery can successfully treat obesity and diabetes in both thin and obese diabetics. That the band, the sleeve, and the Roux-en-Y are failed forms of bariatric surgery. And we'll look at the measures and how I come to this conclusion. And that the mini-gastric bypass is both very safe and very effective over both the short and long term. And we'll use both expert opinion and published data to make that argument. For this lecture in India, the surgeons and physicians in India well know that diabetes and obesity are growing problems in India. This is surprising to non-Indian surgeons such as myself, who had always viewed the primary problems of nutrition in India and other South Asian countries as being inadequate nutrition. But India has been fighting valiantly to build its economy and to grow the economy for the success of its people. And indeed, it has had some success. But along with the success and its attendant growth of individual prosperity has come a tremendous rise in the diseases which have affected the other prosperous nations in the world: obesity and diabetes. If you look on this slide, right now the top 10 countries in the numbers of people with diabetes, India is number 1. India in 2000 had 31 million, projected in 2030 to have 79 million diabetics. In other words, we're getting close to 100 million diabetics. How will this country, which is struggling to gain prosperity for its people, manage such an overwhelming health crisis? Well, I don't want to spend too much time on this telling Indians and Indian physicians about their problem with diabetes and obesity, because they're well aware of it. But suffice to say that all the physicians in India are faced with this growing, serious problem, and it's projected to get much worse. The second major objective has really been presented already in the first study that we talked about, that surgery can indeed successfully treat obesity and diabetes, both in thin and obese diabetic patients. I'll refer to just one more article here, and there are many now in the literature, but that surgery can successfully treat obesity and diabetes in both the thin and the obese diabetic patient. In 2011, Dr. Lee in Taiwan compared the mini-gastric bypass versus the sleeve in a controlled prospective trial. At 12 months, type 2 diabetes was resolved in 93% of the mini-gastric bypass patients. And the mini-gastric bypass had better weight loss, better fasting blood glucose, hemoglobin A1C, waist circumference than the sleeve by every measure. But this and many other studies show that indeed surgery can treat morbid obesity and diabetes in both the thinner and the more seriously overweight patient. The other study is the one we referred to at the beginning. 12 months, 28 participants out of the 60, 49%, Roux-en-Y group, and 19% in the lifestyle group achieved the primary endpoints. But again, as we pointed out, 36% serious complications, 3.6% had leaks, 3.3% had leaks, 1 anoxic brain injury. So those are the first 2 points, and I didn't spend much time with them because I'm going to spend a lot more time on the final 2 because they're more controversial. And I imagine the listeners of this presentation will be more interested in this section as well. I'm going to declare the band, the sleeve, and the Roux-en-Y are additional members of a community of failed forms of bariatric surgery. And that includes the jejunal ileal bypass, the vertical banded gastroplasty, most recently the band, and I think the sleeve and the Roux-en-Y also fail to meet the success criteria as a surgeon, and I think patients should have in selecting an operation. Again, I apologize, but this is not a satisfactory outcome. This is Roux-en-Y, controlled prospective trial, one of the best managed forms of research we can get. It's prospective randomized trial, and the results, I would say, based on safety to the patients, are unacceptable to me. If I was a diabetic to say in the next 12 months, I could choose to have surgery, which would be associated with a 37% serious complication rate and a 3% leak rate, I would not consider this an adequately safe operative procedure. We're going to argue that the mini-gastric bypass is both very safe and very effective over the short and long term. So again, primary 2 objectives met, 2 objectives to attain now. We're going to look at the band, the sleeve, and the Roux-en-Y, and published data and expert opinion. And how will we make these conclusions for the purpose of this presentation? We're just going to be very simple. We're going to say, look, we want 2 primary critical factors to allow a procedure to be declared success for treating morbid obesity and diabetes. We want safety and we want efficacy. And in the absence of that, we're going to declare, for the purposes of this presentation, the operation a failure. Now, what do we mean by safety and efficacy? Success criteria can be listed in many ways. For the purposes of this presentation, I'm going to list 30 success criteria. And I'll go through them quickly. They're part of another presentation I have, but basically, the operation should have low risk. You should have major weight loss. That is safety and efficacy. Ideally, it should be easily performed. Complex procedures have their own problems, potentially both affecting safety and efficacy. It should have a relatively short operative time. In other words, a longer operation is associated with complexity and complications. And so again, my preference would be to recommend a measurement be that relatively shorter operative times are generally better, all things being equal. Ideally, an outpatient or short hospital stay, minimal blood loss, no need for ICU stay, minimal pain, very high patient satisfaction, and a good exit strategy. And what we mean there is very simple. What if there's a problem? I want a way out. If the theater we're in catches fire, I want red exit signs that allow me to get out easily. And again, we'll see with several of these operations, there is not a good exit strategy. We want to change in behavior. We'd like the operation to decrease hunger and increase satiety so that the patient can eat less. We know that we can prevent somebody from eating by putting them in a cage or wiring their jaws shut or something like this, but the patient is not satisfied. The patient remains hungry, sometimes ravenously so, and so what we want from our operation, if we want an ideal operation, is we want that measure of hunger to go down and satiety or fullness or satisfaction to go up. We want minimal retching and vomiting. We don't want gastroesophageal reflux and burning and vomiting when we try and eat healthy foods. We'd like few adhesions. We don't want bowel obstruction and death to be associated with an attempt to fix our obesity or diabetes. The operation should have minimal impact on heart and lung function. We don't want patients to be lost while we're trying to repair their problems with obesity and diabetes. We want a low failure rate. We don't want to see that 75% are successful. We want 93, 99 or more % successful. We'd like a low or reasonable cost, short recovery time with rapid return to work. We'd like a low risk of the tragic, deadly complication of pulmonary embolus. We'd like a durable weight loss. That is, we want that long-term efficacy. We'd like low risk of ulcers or gastritis. We'd like significant fat malabsorption to lower the cholesterol, to lower triglyceride, and decrease cardiovascular risk, that kind of efficacy. Ideally, I think we don't want a foreign body. The data on putting foreign bodies in the body is not good. Plastic in the abdomen has been tried in a variety of situations, including the old vertical banded gastroplasty, Marlex mesh, the silastic rings placed around the esophagus for reflux. They generally don't work well over the long term, so we prefer not to use that if possible. We'd like easily verifiable results, and we'd like 10-year results of efficacy to make measurements on an ideal weight loss surgery. We'd like a low risk of bowel obstruction. We don't want patients to suffer a incarceration and obstruction of the intestine after this surgery. We'd like the operation based on sound surgical principles. We'd like independent confirmation of results. And we'd like a healthy lifestyle. We don't want to lose weight and get rid of our diabetes, but be stuck in some kind of unpleasant or pathologic lifestyle where one cannot eat an apple or a healthy meal. Ideally, we'd like the operation supported by level 1 evidence, randomized, controlled, prospective trials demonstrating effectiveness. And importantly, we'd like the operation to block the sweet eater failure. And what this means we'll talk about later, but basically the band, the sleeve, the vertical banded gastroplasty, and other restrictive procedures often fail simply because Coca-Cola, soda pop, ice cream, and candy can easily beat the operation and lead to recurrence of both the obesity and the diabetes. So, that's the criteria. What's the conclusion? Well, if you don't want to listen to the whole presentation, here it is, very short and simple. Basically, the band is now fading around the world. There are still surgeons who support it. The United States still has many band surgeons, but in India it's been almost completely abandoned because of its failure. And around Europe and other countries, the lap band is rapidly fading. The company itself, I understand, is trying to sell the band making portion of it. They don't want it anymore. The number of bands being placed is going down. And how can we assess the band? Well, short and simple, it's very safe. And the incidence of early complications are low. It's an easy operation, very safe. It's just not very effective. Now, notably, for 10 years, you can find articles saying the band is great and equal to the Roux-en-Y, and this should be educational to both patients and doctors. We should learn from this. People said the band was great, and now we see the band is not. Articles in the scientific literature said the band is a good operation, the band is not a good operation. Articles said weight loss with the band is good, but weight loss with the band is not good. It's not very effective at 5 years, and at 10 years the failure rate is extremely high. How can we make sense of this? there are articles saying the band is good, the band is not good. The reason is that there are some biases inherent. One is to publish short-term data. Many times when you see an article saying includes 5-year data, that's the longest follow-up or the mean follow-up, and they may have many short-term follow-up. And short-term, just like a diet, the band can work for a short term. That's fine. A short-term effectiveness is okay. It's just not acceptable for a $20,000 operation and for an association of serious complications over the long term. Many series are quietly reporting that almost all of their bands have had to be removed. So, very safe, not very effective, and if you look in the medical literature, you can see numerous articles saying the band is a good operation, but that's for short term. And as you see longer term, there are only very rare articles saying long term it's good. Now, admittedly, there are some surgeons, particularly from Australia, and a few others that are reporting good long-term results. This is clearly not the experience of the vast majority of surgeons who have adopted the band. You can draw your own conclusions about their results. They're probably superb surgeons, or there's something about their results that just don't match the rest of the entire world. Next, we're going to talk about the sleeve. Well, the sleeve is following the same popularity curve that the band did almost 10 years ago, and with very little insight by the surgeons and patients who are now adopting the sleeve. They say, oh, it's simple and safe, and so we want to use it, and we don't have 5-year data, but that's okay. And what we're seeing is it's not very safe. We're seeing leak rates reported of 2%, and if you have a practice that has 50 cases a month, that would mean you'd have a leak in your practice every month. And with a hospital stay of 6 months, can you imagine having leaks in your hospital all the time for the rest of your practice? So leaks do occur, and the newest concern is fading effectiveness, that the early effectiveness is attractive, but longer term 5-year data is concerning. Again, like the band, there are several people saying that even 5-year data is good, but that's not what we're hearing. And so we'll look at that in some hopefully less biased studies as we talk about it. But not very safe. Particularly devastating are complications with leaks and fading effectiveness, particularly also a unique complication of the restrictive procedures is the new onset of gastroesophageal reflux in up to a third of patients, and we know that acid reflux in some patients long-term leads to esophageal cancer, so the long-term risk of cancer in these patients is important to consider as well. And finally, the Roux-en-Y, that was the subject of this paper. It was just presented in JAMA. And the complication rates are really stunning, and by report similar to other reports. But we'll look at some other studies, but what we're going to conclude is by every measure, the Roux-en-Y is the most dangerous form of bariatric surgery, by far. And its long-term effectiveness, although it's more effective than the sleeve and the band, has issues as well. So that's the short summary. So we can say again, the band's safe, but not very effective. The sleeve's not very safe and fading effectiveness. The Roux-en-Y is the most dangerous, and even its effectiveness has issues. So we're going to look at some published data and some expert opinion. One article I like is 28,000 patients from the Annals of Surgery, and this is from the American College of Surgeons Bariatric Surgery Center Network. And I like it because of the large scale size. And again, their conclusions is, sleeve's pretty good because it's more effective than the band and not as dangerous than the Roux-en-Y. I look at their same numbers and come to other conclusions, and you can review the article and decide for yourself. I'm not going to go through all this, but basically by every measure, by every single measure, the Roux-en-Y is the most dangerous procedure. By every single measure, the lap band is the safest procedure. And so we can look at a variety of measures, and I won't go through all of these here, but simply we know from this analysis the Roux-en-Y is the most dangerous bariatric surgery. The lap band's very safe, and the sleeve is close to the Now these next 3 or 4 graphs are efficacy. And so we're going to look at reduction in BMI. And this is a nice measure. And so again, we're going to see band, sleeve, Roux-en-Y. Band, sleeve, Roux-en-Y. This is going to be a repeating theme in this presentation. Band had the least effectiveness, so this is efficacy. At 12 months, they've only got 12-month data, but still very valuable. The band was the least effective. The sleeve next, and the Roux-en-Y most effective. So again, we remember the band was the safest, the sleeve was in between, the Roux-en-Y was the most dangerous. Now we have kind of the inverse. The band is the least effective, the sleeve middle, and the Roux-en-Y most effective. So the Roux-en-Y is most effective and most dangerous. The band is least effective and least dangerous. And so if you had to choose the 3, why don't we take the middle? Let's take the sleeve. It's not very dangerous and not very effective. Or it's kind of dangerous and kind of effective. But we'll look into it more before we make our final decisions. Now this is interesting. This is hyperlipidemia. Okay. Now sleeve looks good at the 6-month and the 1-month numbers. But by 12 months, the salutary effects of the sleeve on hyperlipidemia have declined to that of the weakest procedure, the band. So sleeve, great, but starting to fade at 12 months. And hyperlipidemia is fading, and there's a kind of an interesting idea of how that happens, and we'll talk a little bit about it later. And it goes along with ice cream and chocolate candy. All right, this is gastroesophageal reflux. Now we know that there is a salutary effect of the Roux-en-Y on GE reflux, but the band and the sleeve can have up to 1/3 of patients show up with GE reflux, and here we can already see at 12 months hints of this after an initial improvement. Hello? Hello? Wrong number. All right, next we're going to look at diabetes. And again, sleeve looks great initially, but we can see by 12 months the sleeve has bounced back up almost to the level of the band. The Roux-en-Y is most effective, and we see early evidence at 12 months the sleeve is beginning to fail. So, how can we conclude from this study? Well, again, my interpretation is as follows, that the lap band is very safe but has 5-year failure. The sleeve is more dangerous than the band and is right on track to follow the band's failure at 5 years. The Roux-en-Y is more effective, but studies clearly show long-term weight regain and recurrence of diabetes with Roux-en-Y. And unequivocally, the Roux-en-Y is the most dangerous form of bariatric surgery. And just remember back to the 36% serious complication rate and a 3.3% leak rate. Okay, again, in short, lap band is safe but fails. Sleeve is dangerous, more dangerous than the band, but has 5-year failure. The Roux-en-Y is more effective but most dangerous. So what we need, I would argue, is safety and effectiveness. And we're going to argue that that's provided by a mini-gastric bypass. Now, let's talk again about the sleeve. The sleeve is really popular now, and the conclusion from the authors of the previous studies is sleeve is a good choice. So it's reasonable. Here's a separate study of 4,800, in other words, almost 5,000 patients. And their conclusion, again, to me is remarkable. They said the risk of leak is low at 2.4%. The risk of leak is low at 2.4%. Well, compared to 3.3% in that Roux-en-Y study, it is low. But again, let's imagine you do 50 cases a month. That means there's a leak a month in your hospital. That means 1 leak out of every 50 cases. We won't talk about it too much, but the time to heal from a leak from a sleeve, it can be up to a year. And there's a new study by Dr. Chevalier, a friend of mine from Paris. It's devastating to imagine 12 leaks in a year filling your hospital. So sleeve is claimed to be safe, and by this group, by the previous group, here we're talking about a 2.4% leak rate, and they declare it's low. I would say that that is wrong, that we both see the number 2.4%. The authors here say that's low. I am repulsed. I say 2.4% could not be declared to be low. All right. What do the experts say? Well, we did a survey of about 100 bariatric surgeons in preparation for the Mini-Gastric Bypass 1 Anastomosis Gastric Bypass Conference. And we asked them to judge the various operations. So one of the questions, we said, what do you think of the lap band? And we gave them 3 choices. It's good, short, simple surgery, maybe the best form of weight loss surgery. I use it often. Or it's okay and acceptable. I use it sometimes. Or it's a bad operation, should never be used. In our survey, which was maybe biased, maybe not perfect, but it said that only 7% thought the lap band was a good operation, and up to almost half, 46.4%, thought it was a bad operation and should not be used. Now we looked at the sleeve as well, and 32% thought it was good, 14% bad. The Roux-en-Y, almost half thought it was good, maybe the best form. Only 7% thought it was bad. And in this sample, 2/3 thought the MGB is good and maybe the best, and MGB is a bad operation by 3.5%. So MGB had the fewest negative judgments. It was most often judged best. And this is that same data in graphical format. The MGB is successful because of simplicity, power, and safety. So let's look at this. Sleeves are known for their failures. This is a study on failed sleeves, and this is failed sleeves that have failed within 24 months of the sleeve. So within 24 months, they're getting reoperated in this study. The time to failure, less than 24 months, and the primary reason is weight loss failure, diabetes treatment failure, or severe reflux symptoms. And a third were because of severe reflux symptoms, as we talked about in that other study. Now, I'd like to take just a brief moment to comment on the lap band and the sleeve, because understanding how they're created fail will help us understand a little bit more about why we think they're a bad choice. Basically, the band and sleeve are trying to fight against the neuro-humoral drive to eat. They're restrictive procedures, and what they do is they create sweet eaters. And let's see if I can explain that. The nature, the physiology, the construction of the sleeve and the band creates a mechanical block to the eating of normal, healthy foods. And we'll show a little bit more about that in a minute. So this block leads to a honeymoon period of weight loss. In other words, you can't eat a sandwich or an apple or broccoli. A lot of times you vomit them out if you try to eat them. And so what happens is they do indeed lose weight for a period of 1 to even up to 5 years. But then they fail. They begin to gain weight, and they have GE reflux and maybe even a risk of cancer. They have weight loss. They get increased hunger because they can't eat healthy foods. They have a decreased satiety. Healthy foods are blocked. The drive to eat goes up. And then what happens? And what happens is apples and sandwiches and broccoli attempt to go into this area. And here we can see on the x-ray of the sleeve, this narrow area is not going to be conducive to letting a bolus of food go through it easily. And even if you get it partway through, you may have some trouble getting it back. And the same thing's true. Here's a band, and trying to eat into that, and you're going to get this dilation above it. And so what happens is healthy foods are blocked by both the sleeve and the band, and over time then, it's recognized by the patient that these two operations do not block these foods. liquid calories. Ice cream will easily go through that area. Coca-Cola will easily go through that area. 200 grams of ice cream, 540 calories. 2 Milky Way bars, 1,000 calories. 2-liter bottle of Coke. Before breakfast, we've had 2,300 calories. This is what's forced on the patient, not because they have poor willpower, but because they can't eat broccoli. They can't eat a sandwich. They can't eat an apple. So diet, we know, when they're blocked from eating, these restrictive procedures will induce a rise in hunger, be a rise in ghrelin. So diets, along with restrictive procedures like the band and the sleeve, will fail. Attempts to override the Neuro-Humoral hunger system routinely fails, and these restrictive procedures force patients into pathologic dietary choices, making them so-called sweet eaters. So now we've talked about our 3 primary objectives, the band, the sleeve, and the Roux-en-Y, why I declare them failed forms of bariatric surgery. And so let's talk about the mini-gastric bypass. And we're going to make claims that it's both very safe and very effective over the short and long term. We know that diet-induced changes in hunger cause the failure of diets and cause the development of sweet eaters. But we also know that bypass effectively decreases hunger. So what we want is a block to the Neuro-Humoral hunger system, short, simple, durable, 30-minute surgery that decreases hunger and increases satiety. So here's a study from Dr. Noun in Lebanon. 1,000 patients underwent MGB. The operative time was 89 minutes, the length of stay was 1.8 days, and short-term complication rate was 2.7%. They had 0.5% leaks, 4 times lower than reported at low rate for sleeves. Excessive weight loss occurred in 4 patients. Percent excess weight loss of 73% at 18 months. This is a 9-year study from Dr. Lee in Taiwan. Excess weight loss after 5 years was 72%. Of 1,300 patients, 17% had reoperations. In other words, a failure rate leading to reoperation in 1.7% because of excess weight loss in 9, inadequate weight loss in 8, and bile reflux in 3. This is safety. There was no internal hernia or bowel obstruction. This is safety and efficacy. We know that Roux-en-Y doubles the need for hospitalization. In California, from 1995 to 2004, 60,000 patients had Roux-en-Y, and the rate of hospitalization the year after RNY was double the rate of the previous year, up to 19% versus 7.9%. And the rate of hospitalization after MGB declines from 17% before to 11%. So MGB decreases the need for hospitalization. If you do a Roux-en-Y dangerous procedure in bariatric surgery, you double it. Now, MGB versus the sleeve, there are a 12-month prospective randomized trial of 60 type 2 diabetics, matched for diabetes duration, type of diabetes, and glycemic control. Type 2 diabetes resolved in 47% of sleeves and 93% of MGBs. Statistically significant. Weight loss, fasting glucose, hemoglobin A1C, waist circumference, all were worse in the sleeve patients. In other words, simplistically, the sleeve is half as effective as the MGB. So efficacy, sleeve, MGB. 50% effective sleeve, 90% effective MGB. This is our survey from around the world. And again, we're going to see quickly the same thing. Band, sleeve, Roux-en-Y, MGB. Which resolved diabetes better? MGB. Operative time, 68, very similar to the sleeve. Dyspepsia, upset stomach after sleeve and band, very high. Pre-op GE reflux jumps up after band and sleeve. Almost a quarter to a third of band and sleeve patients have postoperative GE reflux. And with acid reflux of the esophagus, we know we're going to face long-term risk of esophageal cancer. Excess weight loss, by far the best in the MGB. Weight loss failure, by far best in MGB. Lost more than 50% excess weight loss, 95%. And again, our deadliest bariatric surgery, Roux-en-Y, bowel obstruction, 2.5%, much higher than the other groups. Ulcers, MGB and Roux-en-Y similar, and no one, not one person, none of our survey respondents said that Roux-en-Y was a short, simple operation. The Roux-en-Y, the most dangerous bariatric surgery, is a complex operation associated with the highest rate of complications in these 4 operations. Do you routinely get major weight loss? The MGB was the best, 95%. Rarely suffer from long-term complications, 70% for MGB. Sleeve, 50%. And 30% of those are going to have esophageal reflux and may lead to esophageal cancer. Published leak rates, sleeve, 2%. MGB, 0.5%. In other words, 4 times higher for sleeve. For Roux-en-Y, we just talked about, that's a 3.3% leak. So what we would say is the expert opinion in summary is restrictive procedures fail, the band and the sleeve, starting at about 2 to 5 years. Restrictive procedures push patients toward liquid calories. Can a sleeve or a band stop a Coca-Cola? Weight regain is common, acid reflux, and acid reflux long-term can develop into esophageal cancer. Why is the MGB so much better? Again, a nice article here that shows that when the duodenum is bypassed, diabetes in diabetic rats resolves. When the duodenum here is bypassed, diabetes resolves. When the bypass is eliminated, diabetes returns. So this study and others have shown that bypassing the duodenum directly ameliorates type 2 diabetes, independent of food intake, body weight, malabsorption, or nutrient delivery to the hindgut. Similarly, studies in gastric cancer patients show that if you resect the stomach and bypass the duodenum, you increase the resolution of diabetes by close to 50%. Another important point that many people are unaware of is new research suggesting that decreasing bile acids can have a major impact on glucose homeostasis, because bile acids, it turns out, are actually hormonally active, modifying the glucose homeostasis mechanisms. So in summary, the survey shows short, simple, effective, and durable operation for the mini-gastric bypass. 30-minute operation with 1-day hospital stay, lower leak rate, best weight loss. It's easily reversible and revisable. We've met our primary objectives. Obesity and diabetes are growing problems in India. Surgery can successfully treat obesity and diabetes. The band, the sleeve, and the Roux-en-Y, using the definitions I selected here for this presentation, I think are failures. They don't meet the criteria of safety and efficacy, and the mini-gastric bypass is shown by both expert opinion and published data to be both very safe and very effective over both the short and long term. Thank you very much.